the last talk will be through the video record. So Dr. D will talk about the rehab needs in Mecp2 Duplication Syndrome children. You're going to share it, right? And if you have questions, you can route it to us through email, and I'll pass it on to Dr. D. And Dr. D is a physical medicine and rehab doctor at Texas Children's Hospital.
Hello, everyone. My name is Rochelle DY. I'm associate professor at Baylor College of Medicine in physical medicine and rehab, and also in pediatrics. And I'm also a full-time physiatrist at the Texas Children's Hospital in Houston, Texas. Thank you so much for this invitation to be with you today and speak to you about rehabilitation considerations in Mecp2 Duplication Syndrome. I sincerely apologize that I had to make this last-minute change. I could not be there to give this lecture live virtually due to some work schedule changes. And so I hope, even though this is recorded, you would still find this helpful. And if there's any questions that you may have, you can feel free to reach out to Dr. Palavan, and I'll be happy to answer them perhaps by email after the talk. And I don't have any financial relationships to disclose. So as we know, Mecp2 Duplication Syndrome brings with it a lot of impairments, as well as developmental delays, be it motor, gross motor and fine motor, as well as speech impairments, as well as intellectual disability, some autistic features, and some problems with swallowing, which is what we call dysphagia. We also have some muscle tone abnormalities. Hypotonia is the most common, and especially in the younger age population, we see very loose muscle, so to speak. They don't have enough of the strength, and sometimes they can develop hypertonia, which is an abnormal tone, wherein the muscles become stiff or overpowers, which can make care and even movement difficult. We also see musculo-skeletal deformities or problems or over time, particularly scoliosis, and also some hip dysplasia and dislocation, and also fractures. So as we see the incidence of musculoskeletal problems, as was reported by Danielle Ta and colleagues in a recent publication in Children, and they have shown that the incidence of neuromuscular scoliosis, which we see in these children, are at about 23%, and it had been reported earlier to be higher than that in the French study. And this is likely because of the cohort, the patients that they had were older. And so it makes sense that they would have a higher incidence and findings of this neuromuscular scoliosis, because we see this more often as a child enters puberty age. And also bone fractures, because in relation to a low bone mineral density or osteoporosis, and because of non-weight bearing, and they are prone to what we call fragility fractures, meaning a little or a small amount of trauma or force can cause a break in the bone. We also see some problems with the hips being out of socket or subluxed, mainly because they are not well placed into the socket. And this is both contributed because there is the underdevelopment or the maldevelopment of the bone on the femur, and it did not form well just because they're non-weight bearing, and also the acetabulum, meaning the roof of the hip joint, is not well developed, and so that causes all the more a tendency for hips to come out of socket and to be displaced. And there's also higher incidence of muscle contractures as well, or shortening, meaning lacking range of motion. This picture is just to show you the study that that was done in showing the time frame that the scoliosis, neuromuscular scoliosis occurs or seen earlier in females about age 7, and where in males it starts at about age 10. And so, as we know, we really try to, given that we know that there are these musculoskeletal problems that occur over time, especially with growth, we would like to try to prevent or minimize the degree or the severity of these musculoskeletal problems over time. And because we know as there's lack of range, there is a, change into positioning, and also causes some repercussions and consequences with regards to positions. For example, seating. If you have your knees bent all the way, beyond 90, it will be harder to put them in a seat and position them well. And also, severe scoliosis would also affect upper limb function. And so, with rehabilitation interventions, there's definitely a menu of these, like different modalities and different services that can be called upon to be part of the rehabilitation team. So we can look at each one of them. And also, we will also look at bracing and some assistive technology and some medical equipments. And then we will end on a brief overview of spasticity management, in children who will have or develop hypertonia. So physical therapy, as we know, is focused on your gross motor control, mainly your limbs and your upper and your trunk. We want to make sure that we maintain flexibility and range of motion and prevent contractures, meaning lack of range, and of course, strengthening both, also improving coordination and posture. And we want to definitely be function focused, right? And we wanted to see how can we facilitate movement, transitions from one position to another, how they can transfer and move around. Of course, standing, walking is a big part of it. And what other equipments they can help with as well as provide family training, so that whatever techniques or principles that are applied in therapy and exercises, the parent or the caregiver can carry them over at home. And as we said, musculoskeletal changes will happen over time with growth. And this is one thing that is special for children that we don't see in adults, which is growth. And so we are needing to be diligent and also monitoring some of these deformities from happening. And some of the goals are to preserve as an upright posture, to also help with social interaction, for swallowing, to have a better position, and also for functional use of the upper limbs. And also it has medical benefits to promote GI motility and also provide better respiratory capacity, as well as pulmonary toilet. And it also, of course, we want to make sure that we incorporate weight bearing as much as possible, and maintain a full range of motion. OT, on the other hand, usually focus on upper limbs functioning, and also activities of daily living, such as self-care, feeding, dressing, bathing, and transfers as well. And so it does need to have a good strength of the trunk to be able to do some of these movements. And a lot of the times there is also impairments in the fine motor and then the dexterity in the hand use. And so this is where we can also use some adaptive technologies, as well as adaptive aids that can help to facilitate some of these function, as well as to facilitate some activities of daily living and self-care. Speech therapy is two-pronged. Some of them can focus on communication, and some can focus on some swallowing skills. So communication can be verbal or nonverbal, but there, as long as there is a way to be able to relay wants and needs for the child, it could be as a low-tech or simple as a switch, or even picture boards, if that is something that would allow a faster and more functional and practical way to communicate in the home, and can be moved further on to progress into like a high-tech type of a gadget. We now all have these technology, eye gaze sensors and all that. So we have all these that can be customized towards the child, and also depending on the use of the setting of the use of it, be it at home or at school or in other environments. In swallowing, we also want to promote oral motor strengthening and coordination, and also some strategies with regards to positioning, how to promote and prevent, of course, aspiration. And some OTs, depending on the state or the countries, some OTs are certified in doing this. So we'll just have to ask and see what are they able to cover. And as we said, this is like an example of, this is actually lower tech now, but this is like an eye gaze device that we're in. You could also have now a lot of the new technology that you could use a touch screen and program it according to the needs of the patient, that can speak for them or just relay whatever they need quickly. Horse therapy or hippotherapy can also be instituted. The principle behind this is that the rhythmic motion of the horse can simulate gait, and it's helpful for trunk strengthening and balance. And also it's for children who enjoy it. It is a form of motivation and also a socialization. And so it both it helps for the emotional and cognitive development as well. Water therapy or aqua therapy. This can also be incorporated as another form of strengthening or physical activity. We are lighter, we know, in water because of buoyancy, and it helps with mobility as well. Warm water, it definitely is preferable because it relaxes tight muscle, and it also activates some sensory receptors. And so sometimes with strengthening, additional weights or other gadgets can be added to promote, depending on what the goals are and what's being worked on. And also music and massage therapy can also improve social interactions, environmental awareness, and also can help with relaxation. I know a lot of times this is something that is really big among our patients with Rett syndrome, and also I see this as well in Mecp2 duplication. You definitely is, a lot of them are usually calmed with it, or just helping them to be able to be in a calm state. And so, as we said, all these, I know I kind of quickly brushed through some of the different modalities in therapy, but of course, every child is different, and there is no standard pathway. However, this can also vary depending on the stage or the clinical stage of development where they are. And also we know that sometimes there's medical issues, or they are sick for a while, then it kind of impedes progression of these motor skills. And so sometimes it has to be halted for a little bit and then resumed. And so it can depend really, it is very much more personalized and tailored according to the goals and the needs and where they are with regards to what they can do. But of course, our overall aims is to improve and maintain function, to prevent musculo-skeletal complications and deformities. And also it depends whenever, if function is limited, we want to also make sure that we provide some opportunities or techniques that can help decrease the caregiver burden and also make care a little bit easier. And as we said, therapy approaches may vary, and one thing can work for one child and may not work for the other. So a lot of trial and not necessarily error, right? A lot of trials can be done in different techniques, incorporating different principles to get to a specific goal. And the one thing that we all, I'm sure, as parents, it's probably also a very difficult, a difficult thing to kind of find therapists who know what to know how to handle or how to go about, making, with the therapeutic goals as well as the techniques, because not very many therapists might be familiar with this condition. And so it would be very helpful for them to be willing to seek out suggestions and collaborate with those who may have experience in taking care of children with Mecp2 duplication. And a lot of the times, I think one of the barriers as well is that therapists expect fast progression or improvements, especially reaching their goals. And so a lot of the times, the goals or the improvements may be very small that may not be necessarily seen or measured in the typical or the conventional way. So this is where some collaboration and education and training may need to happen so that they are able to provide a better, goal setting, so to speak. And of course, family, you are very important. The ideal therapist would provide a feedback and also about strategies and techniques, what's being tried and used, and of course would be willing to change direction and approaches if one seems to be not necessarily working well, and be willing to try different techniques. And we cannot emphasize this more, that family and caregiver involvement is vital in the team approach. And if the goals are not reached, this may jeopardize the continued approval of services. This is especially true here in the US. I'm not sure how it is in other countries or in the UK. But a lot of this definitely is a team approach. Like the therapist provides and gives guidance, but it is really the family to be like incorporating this in daily activities as much as they can. And the therapy setting can vary. And for example, a child may be best served in a clinical setting, meaning the outpatient, if they need access to equipment or they're a little bit more active and they want more strengthening in terms of mobility, as opposed to a child who is more medically fragile, where in a home health may be more appropriate to start with. And so therapy goals and progress would determine the frequency and the duration. And it could be provided over like a short burst program of a high intensity, meaning 3 to 5 days a week, or as opposed to kind of more like a longer term type and, lower frequency, but for a longer duration. Now we move into some of the orthosis or the braces. And so we know that braces or orthosis are there to help support and stabilize joints and also to prevent or limit deformities. We want to improve alignment and provide some stability at the joint segment, and also we want to limit or prevent the progression of some of the deformities in the joint. So sometimes, as we say, like when we have like one joint that is very tight and, curls in this way, then you want to be able to kind of provide some stretching, aside from the manual stretching or the range of motion that caregivers provide, but you want to be able to split them so that to lessen the time that they're in a contracted position. So quickly going over some of the common ones that we use in the legs or in the lower extremities, we have what we call a supramalleolar orthosis, which comes just above the ankle. And the primary effect is really controlling to prevent what we call the foot pronation or the collapse of the medial arch. So a lot of the times, because of hypotonia, meaning low muscle tone, the foot tends to kind of collapse this way. And over time, develops into a deformity. And so what we want is to try to provide some of that support and provide a better alignment so that the child can also be provided some stability as they weight bear and standing and also walking. The ankle foot orthosis, as we see here, goes higher, and it provides more support. It encompasses the ankle and comes up just below the knee. A lot of it can come as a one piece, meaning solid or non-articulated, or it can come as hinged, meaning movable at the joint. But a lot of times for most of my Mecp2 mutation and duplication patients, I found that a solid one, a non-articulated, provides much more stability, and it holds the foot in a much better position to provide that stability, and also in weight bearing, even in walking. A lot of the times they do like that stability that it gives when you provide that solid AFO, so to speak. So for those who are able to walk and need a little bit of that mobility at the ankle, one can cut the trim lines. Make the trim lines a little bit narrow to provide a little bit of that stability, provide a little bit of that mobility at the ankle joint. And also the reason why we want to prevent, we've kind of emphasized, prevention of deformity and also prevention of contracture. The reason for this is because we want to prevent lever arm dysfunction. We see this in children, whether low or high tone, just because, as we said, that they are growing, so deformities can happen. And so a change in the alignment makes the pull of the muscle different, or maybe even decreases the power of that muscle when it's firing. And so that's why we wanted to prevent these deformities from happening, so that muscles, when they contract, they can be more efficient and fire appropriately. Some of the trunk braces or orthosis that we use as well are generally like more non-rigid braces, so to speak. We call them compression garments. Sorry, oops. This is so. Let's go back. All right. Some of these compression garments, we like to, it provides some stability, and also it provides some proprioceptive input. And these are garments that, of course, most of them, this is a DMO, a dynamic movement orthosis. I actually love them, especially for patients or children with low muscle tone, so that they can still self-correct and they have the ability to contract their muscles actively, but provided some of that stability for those who cannot hold it for a very long time. I really don't prescribe, rigid ones, or the thick ones that are rigid, unless it's needed from an orthopedic standpoint, meaning their scoliosis is very severe, then it needs to be corrected early. The problem here is you don't allow the muscles to contract or to strengthen, which is the case that we wanted to really avert. And there are other brands as well. I'm not endorsing that particular brand, but it has a breathable material. We have also Spio or Benic brands that can be used, that can provide a compression garments. Mainly these are like Lycra materials that provide that snug fit to provide also proprioceptive input. In the upper limbs, so we have varied options either to optimize function. It could also prevent deformities and limit self-injurious behavior. So among Rett patients, we use this elbow brace that is movable. They have a whole lot of these hand to mouth, and so you can try to keep this angle at a 90 degrees. And keep it there, allow it to make it stop at 90, but still allow some movements here. Although I know sometimes it doesn't work for them because they are quite a Houdini, and they could still get their hands into their mouth, but this is an option as well, so that they are not just, you could use the PD wraps or elbow immobilizers. However, we know sometimes that can be very frustrating as well for the children. And you have those that could support the thumb as well, or something that would be a resting hand splint like this one. And also as we move on to rehab equipment, and so we want to make sure that we have the input from a good, well experienced therapist as well, with regards to rehab needs, with regards to what the goals are for and how can it be used at home or in whatever setting. Venture should have experience, as we said, experience just because they needed to, pediatric experience because they need to assure the growth potential, and needing to understand for how long this can be covered by the payers, and also for what will the equipment be used. Is this something that would go along with the goals of the parents and the family? Some equipments that we can start with supportive or adaptive seating. You have your gait aids. Your seating devices like your custom manual wheelchair to provide upright posture. This is an adaptive stroller that's easier and lighter weight. It depends. If they have better trunk control, you can get away with this adaptive stroller. But if they have very poor trunk control, a custom manual wheelchair with good lateral supports and head support would be most ideal. With regards to seating for home, you could have adaptive feeding chairs that are supportive, as well as for schoolwork or even just play for upper extremity in function as well. And here are some standards to promote, of course, upright posture, weight bearing, and also facilitate stretching of the legs. Other than just range of motion, we like the other benefits of this, which improves GI motility, as we said, bone health, and also pulmonary health. It comes in different options and designs depending on what the function of the child is. You could even have a mobile one that they could do outdoor, and they could wheel themselves while doing their standing program. Gait aids such as walkers or gait trainers depends on how much support they need. If they're able to hold on to a walker and learn how to be able to navigate themselves. For those who may have less trunk control or less trunk support, a gait trainer with some of this trunk support might be more beneficial. And here are more options or pictures of these gait trainers. And for those who are able to also have a higher level of strength, can even try love strand crutches. Experienced therapists as well, with regards to rehab needs, with regards to what the goals are for and how can it be used at home or in whatever setting. Venture should have experience, as we said, experience just because they needed to, pediatric experience because they need to assure the growth potential, and needing to understand for how long this can be covered by the payers, and also for what will the equipment be used. Is this something that would go along with the goals of the parents and the family? Some equipments that we can start with supportive or adaptive seating. You have your gait aids. Your seating devices like your custom manual wheelchair to provide upright posture. This is an adaptive stroller that's easier and lighter weight. It depends. If they have better trunk control, you can get away with this adaptive stroller. But if they have very poor trunk control, a custom manual wheelchair with good lateral supports and head support would be most ideal. With regards to seating for home, you could have adaptive feeding chairs that are supportive, as well as for schoolwork or even just play for upper extremity in function as well. And here are some standards to promote, of course, upright posture, weight bearing, and also facilitate stretching of the legs. Other than just range of motion. We like the other benefits of this, which improves GI motility, as we said, bone health, and also pulmonary health. It comes in different options and designs depending on what the function of the child is. You could even have a mobile one that they could do outdoor, and they could wheel themselves while doing their standing program. Gait aids such as walkers or gait trainers depends on how much support they need. If they're able to hold on to a walker and learn how to be able to navigate themselves. For those who may have less trunk control or less trunk support, a gait trainer with some of this trunk support might be more beneficial. And here are more options or pictures of these gait trainers. And for those who are able to also have a higher level of strength, can even try loft strand crutches as a gait aid. And of course, we want to also make it fun, as well as and also make it more motivating. And so adaptive trikes are a good addition. And they are usually customized to the height and the support that's needed. And also, this also helps promote dissociation of the movements and for overall strengthening and physical activity that the child can join in with the family as well. And other equipment such as a lift system, be it like a Hoyer lift or something that has a ceiling lift system. These are medical beds wherein you have an enclosure, and it could be adjusted to the height could be adjusted, and also the head of bed can be adjusted as well. And so I guess I would defer to you with regards to payers, what rules they have, and sometimes what's being covered or not. And also, a lot of the times charitable institutions or organizations might have to be also reached out to for some of these equipments. So briefly, I wanted to touch on goals of hypertonia management. And as we said, hypertonia is whenever you have, high muscle tone or spasticity. And so we wanted to decrease that because because it interferes with volitional movement, or even prevents care, or it impedes with care. And sometimes it can also increase or, contribute to the deformity or contractures, or even bony changes, or hip subluxation and dislocation. And so that it impedes also sometimes with dressing, hygiene, and diapering. And so whenever needed, there are ways to try to address this. Examples would be categories of this would be some oral medications. They may be recommended for generalized, meaning the whole body stiffens up every now and then. These are some common medications that we use: clonazepam, diazepam, baclofen, tizanidine, and gabapentin, of course, under the guidance of a physician to be used, because we need to take into consideration their side effects, which most commonly is sedation or sleepiness. It may also increase your drooling, just because their posture is less, just because they're so loose, and also could have some it may increase constipation and some GI upset as well. And so it really is a balance, and depending on what is needed, but oral medications are available when needed. And if it's focal, meaning, as I said, like, a joint is kind of stuck, as long as it's still movable, not fixed, you could try to, inject botulinum toxin into that muscle to relax it and allow to be able to be stretched, and also to provide appropriate bracing to prevent further deformity or contracture. You have many different brands of it. I'm sorry, whoops. And the duration can last 3 to 6 months. It is weight limited. And of course, it is typically covered by insurers. And it is a way to do focal tone management. If you only have one segment, then you could try to address it directly. And for contractures, you could do serial inhibitive casting. Sometimes we would pair that, we do both botulinum toxin injections first. After 2 weeks, then we put them in a cast, and the cast is usually changed every week to gradually improve and provide a stretch. So, for example, a joint is stuck in this position, the therapist or the orthopedic doctor can try to start casting it in whatever they can stretch it, and then after a week change the cast again and gradually increase the range to whatever range can be achieved. And finally, a systemic and surgical way of treating hypertonia or spasticity can be through intrathecal baclofen therapy. If they are refractory to other tone decreasing approach, this is something that can be considered, and the catheter placement can vary depending on the goal for tone reduction. So I know we kind of went through that quickly, and I'm sorry I took a little bit more time than usual, but I wanted to thank you so much for your time and your attention, and also for the families and patients who graciously gave permissions for this photo. And I hope this was helpful, and please let us know, let me know if there's any questions that I could answer, and I hope this was helpful. Have a great day. Bye-bye. Hello, everyone. My name is Rochelle DY.
It's playing again. Okay. Another half an hour torture on the video. So.